From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
My name is Dr. Cynthia Armand, Associate Professor of Neurology at the Albert Einstein College of Medicine, Montefiore Medical Center, and JAMA Neurology web editor. Today, I have with me Dr. Richard Bernstein, and he's here to discuss his work entitled Atrial Fibrillation in Patients with Stroke Attributed to Large or Small Vessel Disease. Dr. Bernstein is a professor of neurology at Northwestern University Feinberg School of Medicine, and he specializes in stroke and vascular neurology. Dr. Bernstein, welcome to the podcast.
Thank you very much for having me.
I know that you are very familiar with this topic. You have had work published in this arena, especially with JAMA Neurology, in terms of long-term monitoring for individuals with atrial fibrillation, those who have had stroke attributed to large vessel disease. But now we are encompassing both large and small vessel disease. Can you tell our listeners currently what the standard of care is for someone who has had a stroke from large or small vessel disease, what it looks like when they go home, what their workup is, and what happens after for primary and secondary stroke prevention?
Right now, I think we do cardiac monitoring in the hospital for at least a day or two, longer if the patient remains in a step down or telemetry bed situation. And I don't think anything more than that is required by the standard of care, as I view it at least, once they go home for patients with stroke where we think we know the cause and we're attributing it to either large vessel disease or small vessel disease.
And how about cryptogenic stroke?
Well, in cryptogenic stroke, based on work that goes back 8 or 9 years, people have gotten into the habit of performing more prolonged cardiac monitoring.
Mm-hmm.
And we've learned that the longer you look, the more likely you are to find atrial fibrillation. I don't like to say that that's part of the standard of care, however, because it hasn't been shown that that kind of monitoring lowers the risk of having another stroke. So while it can be done and it's reasonable, and I order it in selected cases, the standard of care is a very high bar, and I think you need to be sure that something makes a difference in the patient's life before declaring it part of the standard of care.
Very well put. And take us into the inspiration for your current study. What have you seen and what prompted this type of work?
Well, when we learn that patients with stroke of unknown cause, and those are patients with stroke that looks like an embolism, that looks similar to the kind of strokes that we see in people with known atrial fibrillation. When we saw that monitoring those patients led to the discovery of a lot of atrial fibrillation that was otherwise not detectable, a lot of us thought, well, that makes sense because we sort of figured these patients were having an embolic stroke. We simply hadn't found the cause.
Right.
But what occurred to me and a few other of my co-investigators, particularly Dr. Lee Schwam at Mass General, my co-principal investigator, was that we looked for atrial fibrillation not only in cryptogenic stroke patients, strokes of unknown cause, but in every stroke patient. Every single patient that's admitted to the hospital with a stroke gets hooked up to telemetry to look for atrial fibrillation. And if we find it, regardless of the attributed mechanism of the stroke, we treat it, usually with anticoagulation. So we know that in cryptogenic stroke patients, the more you look, the more you find. We wanted to see if that would also be true in the more garden variety standard stroke patients with small vessel disease and large vessel disease, even if we don't think the atrial fibrillation that we find was necessarily the cause of that original stroke.
Right. In general, what would you say would be the probability of someone who has had a stroke of any cause? What would be the probability of them developing some sort of heart condition like atrial fibrillation in the future? Has that been tied?
Well, we know that in older patients with stroke and coronary artery disease travel as a pack.
Right.
And there's a high incidence of coronary disease in people with stroke, and there's an incidence higher than average of stroke in people with coronary disease. So, in terms of coronary disease, there's definitely a fair amount of overlap. Specifically, atrial fibrillation, after a stroke of the type that we enrolled in the study we're here to discuss, most people do not develop atrial fibrillation over the next few years if you just go by standard monitoring and clinical symptoms. It turns out that's not good enough to find all the atrial fibrillation that's out there, but we weren't looking for it, and therefore we didn't find it until recently.
Now, tell us about your study design.
Well, we enrolled patients that are, I would say, commonly seen on every stroke unit around the country and probably around the world. Patients who are on average in their late 50s or 60s with the usual vascular risk factors, high blood pressure, diabetes, who had routine strokes, lacunar strokes, or strokes due to large vessel disease, such as carotid stenosis or intracranial arterial stenoses. And these are patients who would normally be treated with antiplatelet agents. And half of those patients, we enrolled about 500, half of them got an implantable monitor that can stay in for up to 4 years and automatically detect atrial fibrillation.
Mhm.
And the other half were subjected to whatever the standard monitoring was at each study site. So there was a wide range of what that standard practice was. Some patients got an EKG and a few days of telemetry monitoring.
Mhm.
Some got 3 or 4 weeks of telemetry monitoring as an outpatient and everything in between. So we allowed the investigators to do whatever they felt was their usual workup, and that was the control arm.
Mhm.
And the endpoint was how many patients in each group were found to have atrial fibrillation at the end of 1 year. And then we followed as many patients as we could all the way out to 3 years. And it's the 3 year data that we're discussing in this paper.
Right, right. Now, very comprehensive because even 3 years, individuals with monitoring for 3 years, I haven't seen that done in such a long term capacity.
Well, we're only able to do it in the last 8 or 9 years because of the development of technology that makes it convenient.
Right.
These implantable monitors are very unobtrusive, they're easy to put in. I tell patients it takes 3 minutes to do the entire procedure, including putting the band aid on at the end.
Hmm.
And they just automatically detect atrial fibrillation and other rhythm problems without the patient having to do anything. And it's only with the development of that technology that we've been able to get this kind of very long term, very fine grained data on low burden atrial fibrillation. Before then, we were dependent on an occasional EKG or a patient having symptoms.
And that's particularly good because there are many individuals who can have atrial fibrillation and be asymptomatic, which is pretty scary.
Well, the scariest piece of data that I know about this is that a quarter of all patients with atrial fibrillation come to medical attention because they have a stroke.
Yeah.
And those are just tragic
Ugh,
uh, instances because we know how to prevent those strokes with
right.
anticoagulation. It's so effective. And everyone that has a stroke from undiagnosed atrial fibrillation
Mm.
is a missed opportunity to prevent the disaster for that patient.
Right. So, with that, let's get into the results. What exactly did you find with your outcomes and measures?
Well, what we found was first at 1 year, the monitoring group, the group with the implantable monitor, had atrial fibrillation at a rate of 12.5% compared to about 2% in the control group. So, a big advantage for detecting atrial fibrillation with the monitor compared to the control group.
Hmm.
At 3 years, that trend only continued. So we kept detecting atrial fibrillation in 22% of the monitored group, whereas we only detected another 0.6% over that last 2 years in the control group. So almost nothing discovered over those 3 years in the control group, 22% at 3 years in the monitored group.
Wow.
A big advantage of monitoring in terms of detecting atrial fibrillation.
Yeah, that's pretty eye-opening, especially with this type of technology and what could be done and many individuals you can pretty much save in this instance.
Well, that's the rub. We actually didn't see a lower incidence of stroke in the monitored group than we did in the control group.
Mm,
Now, the study wasn't nearly big enough or long enough to be able to detect that, but it's still an open question in the field whether this monitoring and the treatment that results from the monitoring actually prevents second strokes.
mhm.
That's, I think, the most important unanswered question in our field is whether all this monitoring that we're doing really makes a difference for patients.
Right.
And as of this moment, I can't say that it does, which is going back to our earlier discussion, why I would never say that this monitoring is standard of care so much as it is an option to be considered in patients.
Right. In your study, were there certain individuals with risk factors that were more likely to have or develop atrial fibrillation after large vessel or small vessel stroke?
Yes, we found at 3 years that there were a few predictors of atrial fibrillation, and the most important ones were a history of heart failure,
Hmm.
left atrial enlargement on an echocardiogram, or a body mass index greater than 30. So if you had any one of those three, your risk of having atrial fibrillation detected at 3 years went up by fourfold.
Mm,
So because monitoring is expensive and it's invasive, not dangerous, but it is invasive, I try to focus in my own practice my monitoring efforts on patients who have those risk factors
yes.
because I think the yield of finding atrial fibrillation is highest in those patients. It still leaves us with the decision what to do with that information. But at least if I'm thinking about who I want to monitor, those are the people I focus on.
Finding atrial fibrillation is finding atrial fibrillation. How many minutes or how long were the runs of atrial fibrillation that were detected within this study?
Well, to preface my answer, it's important to say that we don't know what that magic number should be.
Okay,
We
okay.
don't know how much time in atrial fibrillation any individual patient needs to have to be at higher risk of a stroke or to benefit from taking a blood thinner as opposed to, say, an antiplatelet agent.
Mhm.
So that's why when you ask me, I don't want you to get your hopes up that I'm going to give you the magic answer. But what we found was that about 65% of the patients had at least one episode of an hour or more,
Okay.
but very few had more than 24 hours on their monitor. So we were mostly in the 1 hour to less than a day burden of atrial fibrillation.
Okay, understood. So my next question goes back to having symptoms or not having symptoms with atrial fibrillation episodes. In the participants of this study, did you find the percentage of individuals who had runs of AFib were symptomatic versus asymptomatic?
Almost all of them were asymptomatic. 88%, I think, was the number of patients with atrial fibrillation that had no symptoms.
Wow.
So we always want to talk to our patients, but asking them if they've had palpitations is nearly worthless in terms of reassuring yourself that they don't have atrial fibrillation. Nothing wrong with asking, but whether they do or whether they don't, it's not definitive.
Now that comes to what's next. What do you do with a patient like this? Obviously, there's a conversation of prevention, stroke prevention with anticoagulants. What would you do with these patients?
I wish I could give you a great answer to that question because we're detecting very minimal burden of atrial fibrillation. These
Right.
patients are not in atrial fibrillation very much of the time.
Hmm.
And we don't really know if these patients benefit from taking a blood thinner as dramatically as patients with plain old atrial fibrillation that goes on for hours and hours, multiple days a week. Those patients, it's a slam dunk to put them on anticoagulation. These folks with half an hour of atrial fibrillation every 3 weeks, for example, we may not be helping them by taking them off their antiplatelet agent, which is proven to prevent second stroke, and putting them on a blood thinner, which may have slightly more risk and may not be as effective. So that, I think, is the most important outstanding question for further research, which is, okay, we found atrial fibrillation in these patients with stroke. Now let's see if we really help them by anticoagulating them.
I'm all about patient advocacy and patients asking questions and kind of probing deeper. Would you recommend individuals to question their physicians about long-term monitoring of this type? I know this is a small study, but based off of your results, where do we go from here and the clinical implications at the bedside?
I think patients and doctors should both consider long-term monitoring in patients with stroke who match the folks that we enrolled in our study. So generally older than 50 with the usual risk factors, diabetes, high blood pressure, prior heart attack, high cholesterol, etc. Now, it's a discussion. It's not something that either side should insist on because of the uncertainty about what to do with the information if we do find it.
Right.
But it's a conversation, and it's never bad to have that conversation as long as we all have some humility that we're not entirely sure what to do when we find it.
Thank you so much, Dr. Bernstein, for this work and the work of your co-investigators. I am, and I'm sure my listeners are also looking forward to your future work in this topic.
I appreciate the chance to talk with you, and I want to send thanks to all of the investigators in the Stroke AF study and the patients that volunteered to help us figure this stuff out.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. This is Cynthia Armand. Thank you for listening.